Welcome everybody. We'll give it another minute or so here to let the last few folks join the meeting. All right. Welcome everybody to our virtual bootcamp summer workshop series. Some of you have already probably joined other sessions earlier this week or last week. Today we're really lucky to have one of the more popular sessions, and one of the things that kind of people get nervous about, go from one of the most popular live series to probably what will be one of the most popular virtual bootcamp series, and that's Ventilator Management, run by Neal Chaisson and Ashton from Cleveland Clinic. I'm your host, Nirav Shah from the University of Maryland. Let's see, go to our next slide here. So we have 6 instructors here today. We have Neal and Ren, as I mentioned, Sam Wiles, Chip Welty and Steve Fox from Cleveland Clinic, who are all fellows there, and Danny Dos Santos, Edgardo Dos Santos from UCSD. And so thank you to all of our instructors today for spending your afternoon with us as we help get our residents who are soon to be our fellows comfortable with some mechanical ventilation pearls. Upcoming VBC summer workshops, you can go to the wiki site. You all have received an email about this site and the username and password, but here it is again for you. We have more sessions that are coming up. We had a wonderful ECMO session yesterday that will be repeated again tomorrow. And then if ventilator management was something that you feel like I just need a double dose of, this will be happening again tomorrow as well. This all would not be possible without the RBC-VBC working group members. Myself, Matt Drake, were the chair and vice chair for the resident bootcamp for ATS 2020. We're sad that we're not in person meeting all of you and getting you comfortable with topics that are going to be important for you as you start your fellowship. But we are very, very fortunate that everyone worked together to get this virtual bootcamp off the ground. One of the last things I'll mention before I turn it over to Dr. Chaisson and Dr. Ashton is that every Tuesday night at 8 p.m. there is a COVID-19 critical care training forum that focuses on teaching critical care topics followed by an open discussion. And really these have been so well received, and if you have a chance to join in, you should be getting emails about it, but if you don't, definitely look on the ATS website for a link to be able to join these. And with that, I'm going to stop sharing my screen and I'm going to turn it over to Dr. Ashton and Dr. Chaisson.
All right, I'm gonna share my screen here. I hope I can share the right one here. So are people seeing my slide here, the boot camp logo?
Not yet.
Not yet. Oh dear.
You want me to share it, Ren?
No, because I want to control it.
While Ren's getting it up, let me just say one quick thing. If you have your phone, there's a lot of QR codes in here, so you can scan them real quick throughout the thing. We'll send the slides out. But that has your Microsoft Teams, that's your Microsoft Teams screen. So just know that there will be some QR codes through the presentation. You're welcome to do it. I'll send the slides to Lauren and Mira so that they can put them on the wiki site. But if you want to use the QR codes during the presentation, that's fine too.
The other thing I'll say, Neal, is that when we go into our breakout rooms, definitely turn your cameras on. We want this to be interactive and kind of going back and forth, and it's a lot easier if the facilitators can see your face. This is no pressure. It's low stakes. We want this to be fun and interactive, so definitely turn your camera on when you go into the breakout rooms. Ren, we're seeing your Microsoft Teams page, not your slides.
Oh dear. Okay. That's not what I want. Okay, let's see.
Can you share the other screen?
Okay, now what are you seeing?
Yeah, there's your slides. Now hit, there you go. Nope. Now switch, go up to the left, top left, and display settings, and switch screens. Or, yeah, swap presenter view and slideshow view. There you go.
How's that?
Oh, beautiful.
All right. I didn't used to be a technophobe, but here we go. All right. Well, so thanks, Nirav, and thanks also to all my co-instructors here. We're excited about this. This is always something we look forward to every year, and I hope that this virtual presentation is valuable to everyone. So here's the first QR code for you. This is if you need access to the wiki site and to our little primer there that's there. I hope you all have that document and that becomes a resource that you can use. So we're just going to just introduce some basic principles before we head into our smaller group rooms and go through a couple of cases. And so we just want to make clear a few assumptions as far as the learning environment here, that we hope that this is a safe space to learn. And, you know, obviously most of us don't know each other here, and, you know, and when you're in a big virtual platform like this, it's easy to feel like, oh, I don't want to say anything, I don't want to look stupid. But, you know, the beauty of it is no one can see you, no one knows you, you know, I mean, if you look stupid, so what? I mean, you know, but a better way to look at that really is that we're all learning together, and really give yourself a license to be wrong. That's okay. And in fact, if you speak up and you say something and it's not true or not correct, that's fine. In fact, there's probably others in the group that were thinking the same thing, and you've helped everybody learn. So in order to keep things going, we're gonna try to, you know, keep this somewhat interactive. And so speak up if you can. If you can't, I guess we'll just look at the participation box, and we'll try calling on people to keep the conversation moving. And we're not doing that to be mean. We're just aware of our time constraints. So let's just talk about a few principles that pertain to mechanical ventilation. And one of the things that is,
Ren,
yeah.
what your screen? There's only like 2/3 of your screen showing for some odd reason.
Is that true for everybody?
Yep.
Yeah.
Well, we'll try this again here.
There you go.
There you go.
Did that fix it?
Yep.
I just reshared the same screen. All right. It's almost as good as turning it off and turning it back on. So one of the things that is intimidating to people when they're getting introduced to ventilators for the first time is the whole idea of all the modes out there, and there are hundreds of ventilator modes. And the good news is you don't need all of them. In fact, nobody needs all of them. Most of us use 2 or 3 modes, and you get to know those modes and you use them and you become better and better at them, and they will answer for 99% of the needs you have in the ICU. But we're just, in terms of ventilator modes, there's just some core principles that we just want to introduce you to. And the first one is the idea of a control variable. And every mode has this, and so what I'm trying to do here is the control variable. If you think about what's going on inside a ventilator, okay, the first thing you have to know is that inside that ventilator there is a monkey, and this is a union monkey. He's only going to do what you tell him to do. He's not going to do anything more than that, and you only get to tell him to do one thing, and then you have to worry about everything else. Okay, and the control variable is the thing that you're going to tell the monkey to worry about, and you get to choose whether you want the monkey to worry about pressure or you want the monkey to worry about volume, and then you are the one that has to worry about the other thing. Okay, and so every mode that we talk about is either a pressure control or a volume control mode, and so we're just going to sort of talk for a minute about the difference between those. And in order to understand that, you need to understand this little equation here, and it's actually a lot more simple than it might look. The idea is that the pressure that the ventilator measures, where the circuit comes back into it, is a combination of an elastic pressure and a resistive pressure. And in the real world, you also have to add in whatever PEEP you put into the ventilator. But the equation of motion says that the pressure in the ventilator circuit will be equal to the elastance of the system, so how stretchy it is, times the volume of air that you put into it, all right? Plus whatever the inherent resistance is in the trachea, the bronchi, and the bronchioles, and times how much flow of air there is through those airways, all right? And so when we think about control variables, just remember, you can tell the monkey that you want him to manage the pressure side, and you'll worry about the volume flow side, or you can tell him to worry about the volume and the flow, and you'll worry about the pressure. If the monkey's doing the pressure, then you're talking about a pressure control mode. And the alarms that will go off if something's going wrong will tell you when the volumes or the flows are too low, because you're going to have to deal with that. That's not the monkey's job. If the monkey is doing the volume and the flow, then this is a volume control mode, and the alarms are going to tell you when the pressure is too high, and you'll have to do something about that because the monkey won't fix that. Okay? Does that make sense, I hope? Then we'll talk a little bit about the respiratory cycle, and this isn't rocket science, nor is it probably new to anybody, but there's an inspiratory phase and an expiratory phase. And when we talk about ventilators and modes, the event that begins inspiration is called the trigger. And there are a variety of things that can trigger the inspiratory phase or a new breath. And the most common ones are time. So you put in a respiratory rate of 12, and so every 5 seconds there's going to be a breath, whether the patient asks for it or not. That's a time-triggered breath. Or the patient may ask for a breath sooner by pulling in with their diaphragm and either dropping the pressure in the circuit or creating inward flow through the circuit, and that will trigger a new breath, okay? So you have machine-triggered breaths and you have patient-triggered breaths. Then at the end of inspiration, whatever signals the machine that it's time to stop inspiration and go into expiration is called cycling. And again, that can be time, it can be when you reach a certain target volume, or you might reach a certain level of flow that means, okay, the breath's over, it's time to exhale, and the mode will respond to that accordingly. The thing to understand here is that this cycle will go, you know, around and around and around, and a lot of the differences between modes have to do with what is the signal that triggers a new breath, and what is the signal that says, okay, inspiration is over, it's time to exhale. And those are some of the fundamental differences in the modes that you'll work with. And also, looking at the little diagram here, you're aware that the inspiratory phase here is not usually 50% of the cycle. It's usually maybe a third, maybe a fourth. In most of us, our I to E ratio, or inspiratory to expiratory time ratio, is about 1 to 2. And in some patients with different disease states, it may be 1 to 3, 4, 5, or even more. Okay, the next thing is breath types. And we're only going to really talk about 2 different kinds of breaths. The first one is a mandatory breath. A mandatory breath is a breath that is either triggered by the machine or cycled by the machine, or both. So if the machine does either one or both, then it's a mandatory breath automatically. No matter what the trigger is or what the cycling parameter is, if it's up to the machine to do it, it's a mandatory breath. A spontaneous breath, on the other hand, is a breath that is both triggered and cycled by the patient. All right, so if the patient triggers a breath by pulling in and dropping the pressure or creating inward flow, that's a patient trigger. And then if the breath cycles when the patient stops inhaling and the inspiratory flow drops off to a predetermined level and the machine says, it's time to exhale, that's a patient cycled breath. If it's both patient triggered and patient cycled, it's spontaneous. And then there are 3 breath type patterns: continuous mandatory breaths, which means that all the breaths are mandatory; intermittent mandatory ventilation, which means all the breaths, or some of the breaths are mandatory and some are spontaneous; and continuous spontaneous ventilation, which means that they're all spontaneous. Now, something we're not going to talk about today, but what you will become more familiar with as you get into more advanced modes and concepts, is that the third parameter that goes into defining a mode is what's called the targeting scheme, which is the criteria or the algorithm that the monkey uses to decide how to adjust the control variable to give you the ventilator conditions that you want. Okay, and then the last basic thing is just a little bit of knobology. You're always going to be able to run into a ventilator you haven't seen before, and maybe that's all ventilators, who knows. But you know, when you walk up to a ventilator that you're not familiar with, there are some things that you can just quickly identify that will help you understand what you're looking at and what's going on. And so this is just sort of my approach. But the first thing I do when I'm looking at a ventilator, and I've got 3 different common vent displays here. There are certainly many others. But the first thing I do is I figure out where the input areas are. What part of the display represents the settings that I have put into the machine or somebody else has put into the machine that are parameters that I want, okay? And then as opposed to that, what areas are output areas? So that will always include the waveforms that you're seeing, okay, which are going to be pressure, flow, and volume, or some, or maybe 1 or 2 of those. And then whatever numbers reflect the interaction between the ventilator and the patient, okay? So you have a set respiratory rate, for example, down here, and then you would have an actual respiratory rate up here in the output area. So then the next thing that you want to do is learn how to highlight a particular parameter and change that setting to something else that you want. And a lot of modern ventilators have a control knob accept kind of a feature where you can touch the touch screen for the tidal volume or the PEEP or whatever you want to change, spin the wheel to whatever value you want, and then either push the wheel or push an accept button to have that be the new set value. Then you take a look at the waveforms, and we'll talk a little bit in our cases about how you make sense out of those. And then the last thing that you want to quickly determine as you're looking at a new ventilator is how you perform any maneuvers that you want to do, like an inspiratory hold or an expiratory hold. And again, we'll go over those in our cases, so I won't spend time on that. But there's usually, you know, in some ventilators, there's a button on the PB840, it's down here, where you can push for an inspiratory hold or an expiratory hold and get the information that you get from those maneuvers. All right, so those are our basic principles. I don't know if we want to take any time for quick questions. Probably not, because I think we want to go right into our cases.
Okay, great. So I'm going to open the breakout rooms, and we'll get started with the breakout rooms. Thank you very much. All right, you guys should be going shortly. We have 20 minutes for this first breakout.
Great. I'm just going to finish up the last one slide.
Okay.
The one key point that you need to do if you lower your respiratory rate is make sure that your minute ventilation is maintained, right? Because look what happened when I lowered the respiratory rate. I didn't change my tidal volume, and all of a sudden I got this alarm that the minute ventilation was disastrously low. Which means that this patient's going to end up with hypercarbia, which is not what we want at the end of our night shift, right? So in order to do this, this is the one time where increasing your tidal volume may be of advantage to you, okay? It's the only time I've ever recommended to a fellow that they might be able to violate the 6 to 8 milliliter per kilogram rule and get away with it, because you have to maintain the tidal volume, okay? And as you can see here, what happened to their flow rate is it starts to go back down to 0, and their auto PEEP essentially corrected down to where their PEEP was because we gave them enough time to expire fully between breaths. All right, thanks.
Great. Thanks, Neal. All right. You guys are back in the main group here. Ren, do you have You're muted, Ren.
Sorry about that. Okay. Are people seeing my slide?
Yep.
This is large group. Okay. So we just want to wrap up with some key points. Keep in mind the equation of motion. You may or may not have anybody in fellowship that's going to make you spit this out from memory. That's fine. That's not a big deal. But what is a big deal is that you understand the relationship of volume and pressure and how to tell which side of the equation you're running. Okay. Keep in mind for oxygenation that your main parameters that you're going to change to improve oxygenation are FiO2 and PEEP. PEEP being sort of a surrogate for mean airway pressure. There are other ways to elevate your mean airway pressure besides PEEP, but PEEP is certainly the easiest one, okay? Keep in mind that tidal volume and PEEP both affect the plateau pressure, all right? And so you're going to have to balance those two, especially when plateau pressure is an issue, like you saw in our ARDS case. And that rate and tidal volume affect your PCO2, all right? When you're trying to improve your air trapping and so forth, remember that rate is your big ticket item. Always look at your waveforms, all right? Remember, volume is useless and your best friend is flow, okay? Pressure is useful, but not as useful as flow most of the time. And then last, we just want to encourage you not to be afraid of the vent. It certainly won't bite you. Now, your respiratory therapist may bite you if you make changes to your vent and don't tell them about those changes. And there's a good reason for that, and that is that respiratory therapists in most hospitals are legally responsible to make sure that what the ventilator is set matches what is recorded in the record. And so if you go in and you make changes to the vent and you don't tell them, then there's a mismatch and they could get into big trouble over that. So make sure that you keep them in the loop. If you're going to change things on the vent, and you'll have to see what your policies are as you start fellowship, but make sure that the respiratory therapist is aware of those changes or is there with you helping you make those changes. And they can be an incredible resource for you to learn about ventilators, and you can very quickly overcome any apprehension you have about making changes to a ventilator. So with that, again, I want to, on behalf of all the instructors and Dr. Shaw and all of the organizers of the boot camp, we want to thank you for participating in this and wish you all the very best in your coming fellowships. Thanks, everybody.
Great. Thank you, Ren.